Thanks, Roger. Can you hear me okay? Is this loud enough? Thanks for inviting me. I have a lot of passion about this subject. The way I describe TMD is it's sort of like the kid in the back of the room, and there's a lot of commotion and other people are getting the attention, and that person's back there like this. Nobody ever calls on them. That's how I feel like TMD's been for a long time. And I'm a huge patient advocate. Do everything I can to help my patients. So I think the patient testimonies today have, which I hear weekly, it's the thing that really drives my continued work in this area. So I've been asked to look at the evidence base for current TMD treatments. These are the questions I was asked to answer. The overview of the range of the current treatments, the strengths and limitations of the evidence, where is the evidence lacking, and what are the recommendations and priorities for research to strengthen the evidence base. So a little bit of background in this area. I think people have probably seen this evidence pyramid many times, but we're going to then pick and take the top level here, randomized controlled trials and systematic reviews in meta-analyses. That's what we're going to look at today. There's many different kinds of ways to weight evidence, and there's some that have 3 levels and some that have 5, and then there's grades of recommendations, and this is the one that I like. It has 5 levels, and then we're looking at level 1 here. So this is a slide I made 19 years ago that showed the cumulative number of scientific articles about TMD, and at the time it peaked out at about 10,000, and this is the treatment studies, which was much less, to 2,000, and then the randomized controlled trials were a tiny number. And then today, as of last night, it's 27,380 articles that use the term temporal-mandibular. So now it's up much higher, so it's off the screen up here. The articles about therapy are about 8,400. It's then also now is much higher. So when we look at the cumulative number of randomized controlled trials for TMD treatment over time, it's a similar kind of story here, where now we have over 750 randomized controlled trials. And so just in the last 10 years alone, there's been an explosion. It's a worldwide, global enterprise. The vast majority are not NIH funded, which can be problematic. So, in the clinic, what we have is we have people come in and we perform treatment. We don't have any controls. So an example that has been happened many times is that if we have pain on the left side here, and someone comes in and they have 8 out of 10 pain, jaw pain, and then they have an occlusal adjustment then on their surfaces of their teeth, which has been done now millions of times, starting in the 30s and 40s. Then what can happen then is then the pain goes down. And so when this happens in the clinician's hands, then it's very convincing that the treatment that you've done has been really valuable. So this is a single case of TMD pain after occlusal adjustment. There's other situations when you do that occlusal adjustment and the people send you flowers, and they're very happy because their pain's completely gone away. There's other situations where you have the patient come back at 3 months and you've done an occlusal adjustment and their pain's exactly the same and they're not happy, and so then you do a touch-up to it, and then they don't ever return. And so you don't know what's happening, but their pain is continuing. So what happens in the absence of treatment for dental caries and periodontoses and malocclusion? So after frustration for 20-some years with a lot of these treatments, then I thought I wanted to think more deeply about why is it so hard for dentists to accept that maybe occlusal adjustment doesn't work. And I think this is part of the reason. So with dental caries over time, what happens, even though we know there's exceptions to this, it generally gets worse. With periodontal disease, what happens over time is that even though there's debate about some of this, but in general, it gets worse. And then malocclusion, at least in adults, so crooked teeth will generally get worse. So most conditions that dentists treat grows worse without active treatment. That's just how things are. So what are some of the randomized controlled trials for TMD show? So this is a randomized trial doing an occlusal adjustment or fake or sham adjustment, so that study's now been done. And so this was an example of the occlusal adjustment group. similar to before. They came in with 7 out of 10 pain, and then the average person had 3 out of 10, 2 out of 10 pain after 12 months. So let's see what happened when they did the sham adjustment, which is on a buccal surfaces, which there's no physiologic effect thought to be possible. And so then you see this is what happened then. So there was no specific effect from occlusal treatment, and I think the proponents then they were surprised about that. But that's what's happened, and that's what Cochrane reviews now support that. There's an absence of evidence that there's any occlusal adjustment actually treats or prevents TMD. So this pattern then is, if you were to look at the 750 randomized controlled trials, they almost all look somewhat like this. And I'm going to show you 3 examples of ones that are from our institution. So this is a randomized controlled trial of occlusal appliances that was done. Ed Trulove was the principal investigator, was NIH funded. So these are 2 different devices that were used, a hard occlusal appliance and a soft one that cost a couple dollars. And this is what they found in that study. So the people were coming in with characteristic pain of between 5 and 6. Then they either had usual treatment by the oral medicine specialist, a hard appliance, plus the usual specialist treatment, and then they have a soft splint. So they had, I think, 25 different secondary outcomes. They had characteristic pain intensity, and also they had pain impact. And you can see that there's no real convincing difference between those groups. Another study that was done with self-care with dental hygienists then did show some effect, and shown here in the red line, although it's not a big effect, but at about a year and a half then, the group with self-care with the dental hygienists was doing substantially better, and you can see characteristic pain is down here in the 2 range, which is very good. And then what about the really tough patients? This is a Sam Dworkin study that he led. In fact, he led most of these studies. Then 6 sessions of cognitive behavioral therapy was able to then be able to reduce down the characteristic pain intensity for these people that had really substantial and severe TMD pain. Then you can see then they sort of grows back together. So to take those 750 studies, they all look about the same here then. But these are all averages. But so both groups commonly improve on average. So we know that some people the pain oscillates, other people the pain will resolve in 50% of the patients. This is one thing we haven't mentioned that much today, but as a clinician, there's a lot of patients that their pain resolves. And if they have effective specific therapy, a specific diagnosis, specific therapy, it's very rewarding. You can, even somewhat complex cases that people can completely resolve and not have their pain return. Because we have effective therapies, just they need to be diagnosed correctly, and then also having that therapy done. Something I just want to mention is that there is something actually higher than systematic reviews now. There's overview studies, and I think National Academy Medicine and Science is actually a leader in some of these, and so it's essentially a systematic review of a systematic review. Hasn't been done, to my knowledge, for TMD yet. So the number of systematic reviews for TMD have had a similar story, and now we have, my count is over 100, and then most of them have been done in the last 10 years or so. So there's been an explosion of work done. So most of these systematic reviews have force plots, and this is one that Jim Frickton led about 10 years ago. It was one of the early ones that looked at occlusal appliances, and in a nutshell, what it does show then is that this is favoring stabilization splint versus a control, so that in this study, then 6 of these studies, they are all showing either very small to moderate benefits for, this has been pain reduction, so this odds ratio, so 2 times more likely to have TMD pain reduction. So the question is then, these are all also averages. So what about the individual subgroups? So we know from this randomized trial and what we see in the clinic is there's people that occlusal appliances completely stops their pain, totally resolves it. We also have people that have some, we believe, some masseteric type reflexes that the appliances will make their pain worse. In fact, sometimes it makes it a lot worse. The average person has mild effects, mild positive effects, or mild negative effects. This is how almost all these systematic reviews of these randomized trials show. As it was mentioned earlier by Jim Frickton, that we can't predict who's going to do best with each therapy. So we have this highly variable treatment response to occlusal appliances. There's a small group that have a great decrease. There's a small group that get a lot worse. And there's people that have minor reductions or no change at all. So how do we predict? There's some promising methods that we use, but it's not talked about much. It's something we need to think about. So the overview then of the range then, there's a lot of different kinds of things that have been used, and this has already been mentioned: occlusal appliances, anti-inflammatory medications, muscle relaxants, behavioral self-management, psychological therapies, acupuncture, different kinds of antidepressants of all different forms, neurotoxin now, which is Botox, anesthetic and dry needling, low-level laser therapy, which I have not used, occlusal adjustment, orthodontics, orthodontic surgery, TMJ arthrocentesis and arthroscopy, injection of corticosteroids, PRP injections, and physical medicine. And there's even more than this, but these are some of the ones I wanted to highlight. So what are some of the strengths and limitations? So with behavioral medicine then, information, reassurance, self-care, relaxation, cognitive behavioral therapy, many of their variations. So in general, the randomized trials and the systematic reviews show small to moderate effects. The thing that's important and that I've tried to highlight for these are that this doesn't always get brought up is that there generally no or minimal side effects for behavioral medicine, which is an important aspect that doesn't always get brought up. In terms of appliances, there's all different types. Then I just showed you that forest plot. Again, generally small to moderate effects in pain intensity. There are side effects that can occur depending upon different kinds of appliances, especially like partial coverage appliances. They can move teeth, cause additional problems, and then a small subgroup where pain can get worse. Medications then, NSAIDs, muscle relaxants, TCA, and SSRIs. Muscle relaxants and NSAIDs have data to show reductions in pain depending upon the kind of patient that there is. Side effects are commonly not reported in these, again, and it's important to point that out. There's injection techniques like local anesthetic in the muscle, dry needling, neurotoxin now with Botox that are being used that have also some small to moderate effects. They don't always report, again, the side effects. They're generally pretty safe, but there can be some side effects. In terms of the dental therapies and other, basically there's not a lot of work, but there's generally no reduction with these kinds of therapies so far that have been shown, and there are known side effects. So some of the strengths and weaknesses then. So the obvious strength is that there's a lot more research being done. It's a global enterprise. It's really exploded. I just look back last year. There's easily 25 new systematic reviews. So there's a lot of activity going on. So that's the good news. The limitation, I'm going to list about 4 or 5. So most use outcomes that don't really measure what matters to patients, which is quality of life, patient interference. So my colleagues Mark Sullivan, Jane Ballantyne have written some articles about this, and this has been impact. And most of the NIH-funded randomized trials are going to have these measures of quality of life and pain interference. But surprisingly, most of these systematic reviews are showing that the vast majority don't have those measures. The other thing that was really striking when I'm looking through all these systematic reviews over the last few weeks, they say almost always the same thing. It's always like, not enough high-quality studies available. The studies included small sample sizes. The studies included quality studies are low. Conclusions of treatment effect are usually equivocal. So maybe 70, 80% of them will actually say, we're not really sure if this therapy is of any value because the research is just too weak. The other thing is that the DC TMD is a huge step forward, but it's not enough. And the correlates of other things like the neural mechanisms, we talked about it today, is the step forward, being able to know if it's acute, subacute, chronic pain. And then also to talk about comorbidities. So there's local, regional, systemic comorbidities that occur with pain, and you need to measure all those. You need to be able to detect them all, and you need to be able to measure them. And these studies are generally, these things are either the people are excluded or they're just not addressed at all. And there's a lot of complexity there that creates the heterogeneity. I think the best analogy I can bring up is that so a study was done with some of my colleagues with chest pain at University of Washington. And so out of 100 people with chest pain that came to the ER, 15 people had cardiac chest pain. The other 85 had pain from all other sources, which was amazingly high. And you think about with TMD pain, I mean, we've made gains, but in a lot of ways, Orofacial pain in your temporomandibular joint area and your face, it's a little bit like chest pain. And so it's not surprising that we are using all these different therapies, but it's so heterogeneous of a condition that they all work a little bit. And there's some that don't work at all, but and then have side effects, but in general, out of these 25 different therapies, they have some benefit. So the key then is to be able to figure out who can do better. And pick those. So not a lot of data on treatment safety. It's rarely addressed, but it's critical, as we've heard today with patient testimonials. I'm just going to finish with a couple of clinical observations. So TMD therapies are chosen. It's usually unrelated to the specific diagnosis present. So this is actually a pretty surprising thing, but I believe it's to be true. Most initial and subsequent therapies are chosen based on the preferences of the practitioner. So you go to one clinic, they do lots of occlusal appliances. Go to another clinic, they start with Botox. Go to another clinic, and everybody gets an MR, and they get a CT, CBCT. They have they don't have any, it's the complete opposite of tailored therapy, which we're attempting and working hard to do. So we obviously need a comprehensive paradigm that addresses all the relevant specific diagnoses, comorbidities, pain mechanisms with specific proven management. Another one is that the first 8 out of 9 patients I saw at the Center for Pain Relief 8 years ago, they had undiagnosed TMD. They'd been in the medical system for 3 or 4 years, and so misdiagnoses are so common. Every day I'm in the clinic, it's something I see all the time. And Bill Gates had a quote a couple months ago, and so I'm in Seattle, so I pay attention to that. And he was talking about Africa and the frustration about lack of being able to help the population there and population health. And he said, sometimes it's good to get a little bit mad. You get a little bit mad, and then you can really get the gumption to go and make some change in the world. And for me, I've gotten a little bit mad about this. It's like it really bothers me. It's like every day in the clinic, I'm seeing misdiagnosis after misdiagnosis after misdiagnosis, and I just put up my hands like, stop. Okay, we've got to stop this. What are some of the recommendations? So what do we do now? And that's, yes, so stop. I think we got to, seriously, I think we have to stop. So this is for my so mindfulness here, right? So I learned at the Center for Pain Relief also, is that we do this: stop, take a breath, observe, and proceed. That's what we do before we go and see patients for all the providers, so we prevent provider burnout. But I really think that we need to stop doing these trials. I think the last thing, right before I went to bed, I thought, after looking over all these systematic reviews, I'm thinking, the last thing we need is one more randomized controlled trial that doesn't have pain impact and is being done in a small sample size. It's not going to be of any value. So I think that we need some specific recommendations. So I think we need to create some overview studies on these various therapeutic agents. So we need to do the systematic reviews. It hasn't been done to my knowledge. We need to analyze the methodological shortcomings of the current previous RCTs and SRs, systematic reviews. We need to make some specific recommendations like consort and impact for conduct for reporting these guidelines, so that the word gets out, because it's a global community now doing this, and if otherwise we're going to keep on churning out these studies that are not valuable. Develop simple diagnostic chairside measures to aid in precision medicine application. I could talk a little bit more about that. Create evidence-based treatment guidelines for new expanded description of the patient groups within TMD, going beyond the DC for TMD. And then I think we need to actually step forward and measure adherence to the guidelines of the community to see how we're doing. We don't have enough practitioners. Most people don't get care that they need, and we really need to measuring what's happening in the community and see if we can really move the needle and be able to really make some help population health. Thank you very much.